Hi, everybody. I'm Cheryl Jackson, and I'm here with Real Talk about Women's Health, presented by Johns Hopkins Medicine National Capital Region. Real excited about this conversation, and it's so needed. I always learn so much, so I'm expecting you to learn as well. Listen, thank you for joining us on Facebook, Instagram. Thank you for joining us on our YouTube channel. We're going to ask that you share it and like it. Share it and like it. Tell everybody about this conversation and join in on the conversation. All right, so I'm going to introduce our panel today as we get into our conversation. We have with us Dr. Mildred R. Chernosky, and she's a gynecologic oncologist for Sibley Center for Gynecological Oncology and Advanced Pelvic Surgery. So welcome, Dr. Chernosky.
Hello.
We also have Dr. Janine Nicole Staples. She is a gynecologic cancer. She specializes in gynecologic cancers, gynecological surgery. Let me slow it down because I'm not a doctor. Obstetric and gynecology for uterine cancer. She's with us today as well. Dr. Janine Nicole Staples. Welcome.
Hi, thank you, Cheryl.
We also have Dr. Puna Razvani, Razavi. Let me get that right. I'm sorry, Dr. Puna Razavi. She is the Director of Breast Imaging in the National Capital Region, Instructor of Radiology and Radiological Science. Welcome, Dr. Razvani.
Thank you. It's great to be here.
And Dr. Hannah Tam Tran. She is also, she specializes in breast surgery and general surgery. So we have some specialists here. Welcome, Dr. Tran.
Thank you. Thanks for having me.
We are excited to have you guys today. This conversation is so needed just from the interviews that we've been doing already, our short interviews that we've been doing on our stations. I am really well versed and acknowledge some of the things. And so some of the information you've already shared, I've been using on my own self. So I'm sure that people have literally been taking this information by heart. So I'm so glad to have this conversation, as we dig deep into it. Let's talk about gynecologic health. Is there a way to prevent gynecologic cancer? And I'll give that to Dr. Mildred Chernosky.
Thank you, Cheryl. So I will try to be comprehensive in how I answer that question. I think the way I like to start it is by talking about the most common cancers. Obviously, when we're talking about gynecologic cancers, we're speaking about the vulva, which is the outer skin area of the female genitalia. We're talking about the vagina. We're talking about the cervix. We're talking about the uterus, and we're talking about the fallopian tubes and ovaries. So if we speak about what is the most common cancer, endometrial cancer is the most common cancer. It is usually a disease of postmenopausal women. You asked the question, can it be prevented? There's only a limited situation in terms of preventing it. Sometimes we can catch abnormalities that are precancerous, and therefore we prevent cancer because we're catching it at a precancer level. So there's going to be patients that sometimes have genetic syndromes that puts them at risk for colon cancer, as well as endometrial cancer. So when those mutations are found, we're monitoring those patients very carefully. And for many of those patients, when they're done with childbearing, we're going to do a prophylactic surgery, which we call a prophylactic hysterectomy, with removal of tubes and ovaries, which is bilateral salpingo-oophorectomy. So that's a very tangible way of preventing an endometrial cancer. Now, when it comes to the average individual, the average postmenopausal woman, which is where we're going to see a lot of these cancer, will tend to get some bleeding. So it doesn't mean that any woman that's postmenopausal has to have an endometrial cancer if they have bleeding, but we want to evaluate every single woman that has any kind of bleeding, whether it's a little spotting, a lot more spotting, because ultimately there are very good ways to evaluate. And the majority of the time it involves just doing an ultrasound and a biopsy of the lining. And we can find these cancers very early. So we're very successful with endometrial cancer detection at an early stage. When it comes to cervical cancer, I think that's basically the prodigy of what cancers we can actually impact. And there are people in my field that think that cervical cancer could actually be prevented altogether if we catch people that are able to have screening. So Pap smears are very known and very commonly done for women. There are very clear guidelines. So a cervical cancer can very much be prevented by women getting the appropriate Pap smear screenings done, along with HPV co-testing. And I can't emphasize that enough. I think we'll be able to talk about just that topic because that is our most successful story of where we were prior to the 1970s before the advent of developing the pap smear and where we are now. So ultimately, is it preventable? Yes, and you can do so by getting a pap smear and HPV testing for the right age group. So the HPV is used depending upon the age in different ways. The third cancer that I want to talk about is obviously fallopian tube and ovarian cancer. We have come a long way. Can this cancer be prevented? It can be prevented in patients that have genetic mutations like BRCA1, BRCA2, and they're getting prophylactic surgery at a time that prevents that cancer from developing. This is also another topic that we should probably talk about a little bit more expanded, but that's a very good way to prevent it. Now, do we have a screening test for ovarian and fallopian tube cancer? The answer is no. So what we certainly advise is having a relationship with your gynecologist, that you're getting annual exam visits, that you're talking about what are your risk factors overall. Do you have a family history of cancers? And being able to devise a plan that can let us have the best hands-on about how do we go about assessing, are you at higher risk than the average population? And that topic alone deserves its own time. So the answer is it can be prevented in the setting of prophylactic surgery, but only patients' mutation can get that prophylactic surgery. I'm going to let Dr. Staples talk a little bit more about the vagina and the vulva and expand any other concepts that perhaps I may have missed.
Thanks, Dr. Chernovsky. So one other important caveat that I just wanted to state is that with prevention of cervical cancer, we now have actually the HPV vaccine. The vast majority, over 99% of cervical cancers are actually are caused by HPV, which is a sexually transmitted virus. And so the HPV vaccine has, been approved for use as for children as young as 9 and now up through age 45, but it's actually recommended for adolescents between the age of 11 and 12. And the goal of that is to, prevent HPV virus before the onset of sexual activity. And so I just wanted to make sure that we had that plug too. So vaginal and vulvar cancers are actually quite rare. And so I think as far as prevention of those, some of them are also related to HPV virus as well. And so making sure to, have your children vaccinated with the HPV vaccine could potentially reduce the risk for not only cervical cancer, but vaginal and vulvar cancer as well. Again, we don't have great screening tests for vulvar cancer, aside from being able to, see your doctor annually, get and do have a pelvic exam performed. So if there are any abnormalities there that potentially need to be biopsied, we could potentially biopsy them, identify a precancer, and then treat that precancer before it progresses to cancer. So very similar to, how we do the pap smears to identify precancerous cells, similar to with uterine cancer. Occasionally, they'll have precancerous cells in the uterine lining. So that's kind of similar to vulvar and vaginal cancer as well. And I will say for most of these women, they do present with some sort of abnormal, whether it be symptom or finding. So if you notice a new bump or lesion or spot on your vulva and it's not going away, then that's something that should be evaluated by your gynecologist, because if a cancer is identified early, then of course that changes everything. So we do screening and tests so that we can identify cancer at the earliest stages. So that gives us the best chance for cure. And if cure is not possible or feasible, that gives us a better prognosis, essentially, by identifying things at early stages.
Got it. So when we have our gynecologic visit, do we specifically ask for screenings, or is that something that usually comes with the gynecologic visit, your pap smear visit?
So there's specific guidelines as to who should have pap smear screening, what age, what interval. And so it's definitely a question that you should ask, because if your doctor is focused on something else, then they may potentially overlook that. So Dr. Chernovsky and I will often get referrals for people who have like, let's say a cyst or mass on their ovary. And so, but that should be a part of our line of questioning to say, oh, when was your last pap smear? If it's been 5, 6, 7 years ago, then that's absolutely something that we need to pursue. So it's always good to question your doctor. Say, I want to make sure that I'm up to date with all of my health screenings. And then let them know, about, usually we'll have a list of questions that we ask everybody, but don't be shy to speak up if something is new or different, especially with your gynecological health.
That's so good. So at what age should you receive these screenings?
So women should start getting the pap smear at age 21.
Okay. And so is it also if that the teenager is sexually active? I've also heard that, or is that too soon?
Historically, that was the recommendation. So historically, the recommendation was to get a pap smear within, I believe it's within 3 years of the onset of sex. However, now we've changed that recommendation to the age 21.
Got it.
Cheryl,
Got it.
I want to add a little bit more because I think sometimes as parents, you want to get things done early, but starting early doesn't always get you to the finish line. So from a practice perspective, I've been able to see through the evolution of my career, when we did do pap smears within 3 years, within onset of intercourse, or pap smears starting at 18. And what happened and what we have learned historically is that HPV abnormalities will arise related to onset of sexual activity. However, the young cervix has the ability to heal. So I've been in practice now for about 22 years. And so I was one of those people, because that was the standard of care, that we were treating precancerous abnormalities that can develop in that very young population. But what we realize is that that very young cervix has capacities that are no longer possible, perhaps when we're in our late 20s or even 30s, to the extent that we were perhaps doing too many excisional procedures to the cervix, that was then leading to perhaps a woman at 26 having her first baby, had 2 to 3 excisional procedures. Now she's at risk for preterm labor, preterm delivery. So the guideline about starting at 21, I can't emphasize that enough, because regardless of sexual activity, whether they started at 15, whether they started at 13, it doesn't make a difference in terms of finding a need to do any procedures on that very young population. So if we look, we're going to find it. But if we find it, we're going to be feeling the need to do procedures. And we find that that is not necessary. We did a very long study that looked at who are the women getting cancers. And we are just not finding cancers in the woman less than 21. And once we realized that, we realized we had to back off. So that's very important. Every now and then you'll still get very young women being screened, and then you're in this awkward place. So no pap smears at all should be done prior to age 21, regardless of sexual activity. And I want to put in that plug that Dr. Staples emphasized. The best thing you can do for your children, since your children at age 11 and 12 are still under your parental consent, is please give them that HPV vaccine with the same enthusiasm that you're giving all of the other vaccines necessary.
That's so good. That's really good. And how often should we, I know yearly, once we're 21, like you're stating, yearly we do our pap smear, but how often are we to get screened?
So actually, the most up-to-date recommendation for pap screening is between the ages of 21 and 30. It's every 3 years. And it's with what we call cytology alone. So the pap test essentially is twofold. Has two components to it. One is the HPV test, and then two is the cervical cytology. And that's essentially looking under the microscope to determine whether the cells look abnormal. And if they do look abnormal, how abnormal they look. And we describe, precancerous lesions of the cervix as dysplasia. And so there's low-grade dysplasia that can often be watched and will essentially clear itself, and high-grade dysplasia that requires treatment. So from the age of 21 to 30, we're actually not doing HPV testing unless there is some sort of abnormality on the cytology. So it's cytology screening only. Between the age of 31 and 65, a woman should have co-testing, which is HPV automatically and cytology, and the cytology component too. And technically, if you've had normal pap smears in the past, the most recent guideline recommendation is to do that every 5 years.
Mhm.
So it's important to know. A lot of times I think that, just with misinformation and a misunderstanding of things, people will think that they had a pap smear just if they've had a pelvic exam. But just
Mhm.
because you've had a pelvic exam does not mean you had a pap smear. And that's something that should be discussed with your doctor so that we're all on the same page. And if you do have a pap smear, it's important to follow up with, to get results. If you haven't heard back from your doctor in a few weeks, reach out to the office. Don't make assumptions. So it's not an annual pap smear anymore. There's specific guidelines, 21 to 30. It's every 3 years with cytology alone. As long as cytology is normal, we don't do HPV testing because, like Dr. Chernovsky was explaining earlier, many people will have some strain of HPV, and then we start doing interventions that are likely unnecessary because most of the time the body will heal itself that young. But then when we're older, 30 to 65, it's cytology with HPV, and it's every 5 years, assuming that it's negative. Now, if you have an abnormal pap smear, the pap smear is considered the screening test. That's where we're initially trying to identify if there's any abnormality. The diagnostic test is actually a biopsy. So we do something called a colposcopy if someone has an abnormal pap smear. A colposcopy is where we basically clean the cervix and upper vagina with vinegar, believe it or not, and that causes all the cells to become dehydrated. Abnormal cells or precancerous cells look different when they're dehydrated compared to normal cells. And then we look basically under a microscope in real time and see any of the abnormalities there. And then we actually biopsy those areas. So that's one step further. So we consider the HPV vaccine primary prevention. We consider the pap smear secondary prevention. So that's your screening test, but you can't make assumptions based off of a screening test. You got to do, a colposcopy with biopsy to confirm exactly what the abnormality is, exactly what degree of dysplasia a woman has. So yes, so we're not doing annual anymore.
Got it. Got it.
Mhm.
So what about, I'm asking for a friend. A friend is me. What about women of a certain age, that's 50 and over? Are we still expected to do our pap smears every 3 years?
Definitely. So I want to add on a couple nuggets. I think Dr. Staples explained it really, really nice, really succinctly. So it's from age 21 to 29 years old, every 3 years, only pap smear. From age 30 to 65, it's going to be pap with HPV, and we refer to that as co-testing.
Okay.
Over 50, you're still in the bubble of up to 65. Now, I want to expand a little bit more because I'm sure a large sector of your audience is over 65. And so this is a very important point, and it's a point very near and dear to me because there's very, very clear data that from 30 to 65, great, we're getting those pap and HPVs, great. If we have a double negative test, fantastic, we're doing that every 5 years, no problem. But what happens after 65 really depends upon, I think there's this concept of the same ruler for everyone. And the reality is every cervix carves out what's going to happen to it after 65. Let me explain. So if a patient has lived in the same area, has been lucky enough to have a gynecologist, so there is fantastic data that from age 55 to 65, she's had nothing but, 2 negative pap and HPV, so double negative. And she knows more. She even knows that she's had a bunch of these pap HPV negative. Same doctor, patient knows it, reliable data. The patient is still monogamous with the same person, no new sexual partners. That patient and that patient only, with the counseling of her own gynecologist, not her friends, not her neighbor, but her gynecologist. The decision can be made between 65 to 70. You got all this negative pap smears. You're with your same lovely husband. We can stop pap smear screening, but that doesn't mean that that patient does not continue going to the gynecologist. There's plenty other stuff to talk about, plenty other stuff to address. It is just one aspect of that patient's health. there are many times that you're going to encounter a 65, 67, 68-year-old woman who perhaps very much had a bunch of negative pap smears, but her husband passed away, so she's now a widow. She is out there trying to find another partner in life. So for practical purposes, she's an 18-year-old looking for a partner in life. So she's going to be exposed to HPV. So that 65, 67, 68-year-old widowed woman who is engaging in intimate relationships with new partners very much continues getting her pap smear business as usual. Sometimes we may find that those patients, as they engage into, intimacy, vaginal intercourse being a more common form of interaction, may very much have HPV positivity. That is not the end of the world. It just means that she's being exposed potentially to new HPV subtypes. And so that patient may very well end up with a colposcopy. But HPV positivity does not equate that something has to be wrong, as in a precancer condition or even cancer. Over the years, I have seen patients that live and feel stigmatized by, I have HPV, like mea culpa, I am Bloody Mary. No, it's okay, because all of us at some point will be HPV positive, and we keep our viruses. Our immune system can suppress them, but every time as we get older, sometimes that HPV may surface. So do not be concerned about, I have HPV, this is the end of the world. You're just going to stay on that yellow brick road of, perhaps you need a colposcopy, and that guidance is going to be coming from your gynecologist. So there's all too many stigmas that sometimes society imposes. Don't let HPV be another one, because ultimately we just need to investigate what's going on. And a lot of the time it just means that there's some HPV changes, but we don't find dysplasia, in which case that we're going to continue monitoring that patient. And what frequency will depend upon the abnormality. So those are very intimate conversations that the gynecologist is going to ask. What is your sexual activity? Are you a widow? Are you with new partners? So a person may be a serially monogamous person that has monogamy with a given partner, but maybe that one didn't work, so they have another one. So ultimately, these details are helpful to your gynecologist to better guide how do we go about the over 65-year-old population as it pertains to pap smear screening. So that's really important.
Got it. So talk about some signs and symptoms of gynecologic cancers, and let's even talk about how treatment has advanced. Either you, Dr. Chernowski, or Dr. Staples can take both of those. And then we'll get into talking about breast health, but let's go ahead and talk about some signs and symptoms of gynecologic cancers, and then how cancer treatment has advanced.
Let me think about the symptoms, and I can always add a little bit, but in terms of symptoms, just kind of starting from the top up. So when we look at endometrial cancer, that is the most common gynecologic cancer, which means below the waist for females, obviously. Above the waist, obviously, we have breast, and Dr. Razavi and Tran will speak lots about that. So postmenopausal bleeding should always be investigated, not because something awful has to be happening, but the prerogative is that we need to find who are the patients that have endometrial cancer. Sometimes it could be endometrial cancer. Sometimes a postmenopausal woman may actually have a cervical cancer. That can also lead to bleeding. So bleeding in a postmenopausal woman always requires an investigation. Sometimes I see, unfortunately, that people will say, I've only been spotting, so it must have not been that important. Any form of bleeding we want to investigate, not because something has to be wrong, but you bring that to the attention of the gynecologist. That's sometimes the way that cervical cancer can present. Cervical cancer in any woman, though, bleeding after intercourse doesn't have to be cancer. It could be something as simple as a polyp, but we're going to want to investigate that. So what we call it postcoital bleeding, or bleeding after intercourse, always also requires an investigation. As it pertains to the vulva, the most common symptom that people may present with is itching on the vulva, or perhaps, and that may be a sign of a yeast infection, but sometimes it can be a precancer condition called vulvar dysplasia. So if you have any abnormalities, like Dr. Staples mentioned earlier on, if you have a bump, if you have a bruise, if you have an ulceration area, if you have an itchy spot that won't heal or won't go away, that needs to be looked at, and a biopsy needs to be taken. Now, speaking about internally, another organ that is perhaps one of the toughest ones for us, when you speak about ovarian cancer doesn't have a screening test, number one. Number two, it doesn't have something that's specifically that if present means the person has ovarian cancer. What do I mean by that? It's kind of like a series of symptoms, perhaps some bloating, perhaps some constipation, perhaps some urinary frequency. So if your abdomen is getting distended and you really can't attribute that to weight gain, or if you're not sure, so any kind of conglomerate of symptoms that either involve the urinary tract, the gastrointestinal tract, or bloating, or swelling of the lower extremity, it's very easy to do an ultrasound to assess that those ovaries are fine. As it turns out, ovarian cancer is not the most common kind of cancer that we have, but it's the one with the highest mortality, and it's one of the ones that we don't have a screening test for. So ultimately, any of that conglomerate of symptoms is going to be helpful. I want to also point out to Brian, who's I know helping you there at the station, there's going to be an email, an address of a website about the Foundation for Women's Cancer. It's a very good website that has all of this information, and I see it there right now, about symptoms to look for. It has information about where to find gynecologic oncologists throughout the entire United States. You put in your zip code, you put what radius you want. And so it's a very robust website. It also talks about the modalities of treatment for patients that have gynecologic cancer, and it will dabble with a lot of the breakthroughs that have happened. So that's a very excellent resource for people. And I want to pass it on to my colleague, Dr. Staples, about breakthroughs that we have had in the gynecologic cancers.
Thanks, Dr. Chernovsky. So I think here more recently, we're kind of shifting towards a bit of a kind of personalized medicine. It's not necessarily one size fits all. And of course, we know that, depending on the type of cancer, the stage of the cancer, the actual histology or cellular makeup of the cancer, that's going to determine kind of what your treatment course is. There are some still kind of standardized first line treatment for ovarian cancer, for uterine cancer, but things are changing all the time. And now we're doing a lot more, like Dr. Chernovsky said, endometrial cancer, which is the inside lining of the uterus. That's the most common cancer that we see. And so now we're doing a tumor testing and to determine whether the tumor has certain characteristics that would make it more eligible, I guess, to receive certain type of treatments. Because again, it's not one size fits all. So just because one person did really, really good with this type of treatment doesn't mean another person will. There's, 3 general modalities of treatment for cancers. There's surgery, there's radiation, and then there's systemic treatment, which means, chemotherapy, immune therapy. Sometimes we do, oral hormonal or anti-hormonal medications. And so one of the things that we actually do at Sibley Hospital every 2 weeks, we have a multidisciplinary tumor board meeting where the GYN oncology team meets with the pathologist, the radiologist, the radiation doctors, the chemo doctors, all together, and we kind of present each individual case or patient, and we come up with the best treatment plan for that patient. And so I think that there's been a shift in maybe the last decade, 10 to 20 years or so, where it's treatment has kind of become a bit more personalized. But I do want to just repeat one more plug for the HPV vaccine. I truly believe that's probably one of the biggest breakthroughs, I guess, in GYN cancer and GYN cancer prevention, because in 2023, we should not still be seeing, young women die of cervical cancer. That just should not happen. And so I can't reiterate that enough. Please, get your children vaccinated for the HPV vaccine, and make sure that you're going to your primary care provider or primary OBGYN annually to make sure that you're getting the appropriate screening and treatment that you need.
That's so good. And it really is disheartening that so many people are afraid of the specific vaccines, but we get vaccines for everything to prevent us from getting these deadly diseases, even outside of women's health. So why not get the vaccine that you need, so that in the long run it's going to help you. So I'm really excited about having this conversation and us talking about it, and specifically talking about having the conversation for those who are watching on our Facebook page, on our YouTube page. Leave your questions or your comments. We have the experts here, right? They're able to answer the questions that you have with regards to women's health. We're talking about gynecologic cancers and gynecology. We're going to be talking about breast health, and we're going to be talking about some other ways, talking about radiology and mammograms and things that we need to do to prevent having these deadly diseases. And we have the ladies here, honey. You've got the ladies on the panel who's going to be able to answer the questions that you have. So be sure to leave your questions in the chat on our Facebook and our YouTube page, and we'll address them. So let's talk about breast health. So we're going to talk now. Let's talk about mammograms and why mammograms are important. So Dr. Razavi, talk about mammograms and why they're important.
Well, thanks, Cheryl. I mean, what we need to start with is what we know. We know that every year over 260,000 women are diagnosed with breast cancer in the US alone. And every year over 40,000 women die from breast cancer in the US alone. So we know that we're not at a point that we can prevent breast cancer from happening, but we have the tools to find breast cancer early. And early is the best way. If we find it early, we can treat it early, and we can hopefully keep the patient from dying, to reduce the mortality and morbidity associated with breast cancer. So that's our goal when it comes to breast imaging. Screening is key. We know that screening, to have the best early detection, we need to have screening start early, start at 40. Why do I say 40? Because out of every 6 breast cancers, one of the women who's diagnosed is in her 40s. So it's really important to start early and do it annually, because the reason we say do it annually is because we want to find the cancer when it's small, when it's not palpable, when it hasn't hit the lymph nodes yet. We want to find those cancers that are screen detected. We find those cancers that are screen detected before hopefully when they're stage 1 and not gone to the lymph nodes. And then we work in coordination with our breast surgeons who are dedicated to breast surgery, and we hand off those patients to the breast surgeons so that they can provide the excellent care and make sure that they become disease-free and stay disease-free. So from our standpoint, screening is key. We can't prevent breast cancer, but we want to find it early.
Mm-hmm. Absolutely. And so at what age should you start receiving those screenings, and talk about how often?
Right. It should be at 40. And the reason at 40 is because 1 in 6 women who are diagnosed with breast cancer are in their 40s. Mm-hmm. So all the studies have shown that, to decrease the morbidity and mortality, you need to find cancer early. And to do that, you need to do the screenings annually, meaning once a year, and starting at 40 until the patient is good, as long as the patient is in good health. There isn't a year that you stop doing mammograms. We have patients in our population that are in their 80s and in great health. So there's no reason to stop the screening. That's a conversation to have with your referring physician, with your primary care doctor.
That's really good. When you can really, when it comes in your backyard and you actually see it and know it and feel it. And I know a lot of our audience probably can attest to the same thing. My sister-in-law was just diagnosed with breast cancer, but it was found while having her annual mammogram. And so they caught it earlier, and thank God it hadn't gotten to her lymph nodes. She did have to do a mastectomy, but I mean, we were okay. She's okay with that, in the fact that they were able to catch it so that it wouldn't spread and turn into something even, deeper had it gotten to her lymph nodes and gotten throughout her body. So, I will attest to it too. I scream it to the top of the mountains when it's come to your backyard and you can actually see what happens when you get screened and what happens when you stay on top of your screenings. I agree. So, yeah.
Yeah. So for the average population, I mean, your sister-in-law is the best example of the success story of a screening mammogram. And I should tell you that there are other patients who are at a higher increased risk, who have the genetic mutation, for example, the BRCA patients. Those patients should start even earlier than 40. Those patients we need to be very aggressive with. We should also add a supplemental screening with breast MRI, because we know that those patients have a higher lifetime risk than the average patient. So we really do want to be more aggressive with their surveillance. But those patients should have that conversation with their referring physician. Of course, we're always here to answer any questions as well.
Yeah. You know, and again, family members, aunt who passed away with this, so her children was getting screened early. And one daughter did have and ended up having getting a double mastectomy. She did double basically because it ran in her family, right? So she had breast cancer in one and she did a double. And that's 10 years ago. So you know what I mean? So screening, I know, I mean, I scream it to the top of my lungs, and I have a daughter. So you know, I make sure that we're on top of it because, you know, things change swiftly. So it's good to be able to detect because of the screenings that are available. Now, what are the advances of breast cancer treatment? And so I'm going to give that one, of course, to Dr. Chinosky. I'm sorry, not Dr. Chinosky, Dr. Tran.
Yes. So, along the same lines as what Dr. Staples mentioned, there's been such a great advancement in breast cancer care. And I think really it comes down to personalized medicine. Now we know so much more. We know the characteristics of the cancer. We know what feeds it, what it's promoting its growth. And now that we know what are those features, we then do treatment based on that. So before it used to be everybody got the same treatment. Nowadays it's not like that anymore. And I think that's one of the greatest advancement. And I think we have to be proud of ourselves for coming this far. With that specific and specialized treatment, some patients who have breast cancer may just need surgery and then maybe a pill. That's all they need, like a hormone blocking pill, because the cancer is being fed by their hormones. So that may be all they need. Other cancers, we learned that some cancers are more sensitive to chemotherapy and some cancers are resistant to chemotherapy. Now we have better tools to kind of test that. And once we know that information, then we can talk about, okay, these are your options. This is what your cancer is going to respond to. This is what kind of treatment that you need. And if chemotherapy is resistant, the cancer is resistant to chemotherapy, then you may not even need chemotherapy as a part of your treatment. So don't always feel that, oh, I have breast cancer, I'm going to have chemo, I have to remove my whole breast. No longer the case, right? I think the other thing is you hear about the aggressive cancers, like the triple negative breast cancer, that's the hormone negative cancer, or like the HER2 positive cancer, where patients used to have a very bad prognosis when you hear that. Nowadays, we have very good treatment that are very specific for those cancers. And sometimes we even start those treatments even before surgery. And the advantage of doing that is that a lot of times, like 50% of the times, the cancer dies completely, is wiped out. And if that happens, I can do less surgery. Like a patient with a cancer that comes in and then I have to say, oh, I'm sorry, I think you have to need a mastectomy. If the cancer shrinks and it gets smaller, I can do a lumpectomy. And that means just removing the area of the cancer and leaving the rest of your breast tissue alone. So those are all of the exciting advancements. And then, based on that information, like if we get treatment first and we find out how the cancer is responding, if you have a good response, okay, great, we're going to continue the same treatment. But if we find out that the cancer is not responding because it's resistant, then we know, okay, we can't continue the same process. We got to change it up. And that, also equates to better outcomes. So, that's in terms of like treatment. In terms on the surgery side of things, we're doing a lot more lumpectomies, meaning just removing the area of the cancer and saving the breast. And then we follow it with radiation. And then those outcomes, doing the lumpectomy and the radiation, the outcome is actually the same, if not slightly better than even doing a mastectomy. I know. So that's another thing that we've come along in terms of surgery. And then the most important thing is lymph nodes. Usually, you hear whenever I have cancer, I have to take out lymph nodes. I have to take out all my lymph nodes, and then potentially my arms can swell, like the lymphedema. Nowadays, we're actually doing much less lymph node surgery. We try to scale back away from doing that, axillary dissection where we remove all of your lymph nodes. We try to just take out a few lymph nodes and see what's going on first. And then based on that information, we can then talk about additional treatment that's going to help tailor the treatment and then decrease morbidity or risk and decrease your risk of having the lymphedema. So lots of advancements. And I think, we work as a team here. Our radiologist, myself as a surgeon, our medical oncologist, our radiation oncologist, even our pathologist, who looks at everything under the microscope. We meet on a weekly basis and we review cases. So we work as a team to kind of come up with this plan for each patient, which I think is one of the, I love the team that I work with. So really important that you get into a breast program where there's this kind of communication that goes on so that they can come together and make a good game plan or a good treatment plan for you.
I love it. One of our viewers says, this is great information, much needed. And thank you. So I love that they're responding. Great information. Thank you, Ralph. Thank you, ATN, for checking in. And for those who are watching, don't forget to share on your page. Don't forget to share it. Drop your comments if you have questions. Maybe you have a family member dealing with something and you may have questions that you want to ask our doctors. That's why we have the experts. Or maybe you just want to take in the information, and that's fine too. But just want to make sure that we're able to address whatever questions you have or whatever comments that you may have. All right. So I love this because why is it important to have a program? Because you talked about how you're able to interact with all of your team members, right? To have a program that has imaging, diagnosis, and surgery all in one center.
Mm-hmm. I think I'll let Dr. Razavi start with this because most of the cancers are generally found by mammogram, and she's the one who starts it all. She's the one who finds it, and then she starts the process. So I'll defer that to Dr. Razavi.
Okay, good.
Yeah, thank you. So it's really a team approach here. We at all the Hopkins sites and at the NCR, which includes Sibley and Suburban, it is a team approach. Most of our patients are screen detected, which is patients that, again, don't feel the lump, don't have the symptoms yet. And I'll defer to Dr. Tran to talk about the symptoms that patients should be looking out for when it comes to breast cancer on their own self-breast exams and their symptoms themselves that they detect. But when we find a cancer, so we find the abnormality on the mammogram. We actually, me or one of my colleagues here at both sites at Sibley and Suburban, do an image-guided needle biopsy, which means whatever we found on the imaging, we use a small needle, we numb up the breast, we put the needle in and take some tissue samples and send it to our Hopkins pathologist right here at the Sibley and Suburban sites. They look at it and they'll come back with the results. We call the patient, we discuss everything with the patient, and we do a smooth handoff to one of the surgeons that, like Dr. Tran, who just specializes in only doing breast cancer. And that's what's so important, is that we make sure everyone is specialty trained in just this one field, and that's breast health and breast cancer treatment. And so what happens is, as Dr. Tran alluded to earlier, we meet as a team every week. We discuss every new breast cancer patient. Me or one of my imaging colleagues shows the images up on the screen for everyone to look at. The pathologist shows the pathology slides for everyone to look at. And the surgeon, it becomes the team leader in coordinating the care between the other specialties in terms of, does the patient need anything else, such as oncology or radiation? And I'll let Dr. Tran take over from there. But again, it's a coordinated approach, and the studies have, anecdotally, we know it works because patients do better, but actually studies have shown that when a patient has a seamless approach to their breast cancer, and the patient, we don't rely on the patient to coordinate their care, but we take care of it, the patient just does better.
Got it. All right. For more information, we just got message. For more information, visit hopkinscancerdc.org. hopkinscancerdc.org. All right. So for more information, that's what we just got from our center. Get it from hopkinscancerdc.org. All right, ladies. So what should all women know about both prevention and diagnosis? And we're still talking about breast health, I believe. So Dr. Tran?
Yeah. Oh, sorry. I have this special timer here for my lights. I think prevention for breast cancer is key. Prevention and early detection. Prevention. So there are known risk factors that we can control. A lot of times, unfortunately, 60 to 70% of the times breast cancers just occur because it occurs. It's out of our control. But the few others, and that's because of genetics. So if you have a genetic mutation or you have a strong family history of breast cancer, we definitely want to get that screening early. We generally say, like Dr. Rizavi, if you don't have any family history of breast cancer, you start at age 40. But if you have a family member with breast cancer, you want to start 10 years before that youngest person. So if somebody is like 45, then you got to start at 35. Okay. Some patients always ask me, are there any foods or anything that can increase your risk of cancer? The only thing that we do know of that can increase your risk of cancer is drinking a lot of alcohol. Anything 3 or less drinks a week is fine. Anything more than that, we don't encourage because it does increase your risk of breast cancer development. And then that's really all that we can talk about in terms of prevention, because everything else, like I said, just happens. In terms of detection, definitely get your mammograms. I just want to share some quick facts. If your cancer is found and it's only in the breast, your 5-year survivor rate is 99%, 99.1% actually. If the cancer is found when it's both in the breast and the lymph nodes in your armpit area, your 5-year survivor rate goes down to 86%. That's still very high. That's great. But if your cancer is found and it's like elsewhere in your body already at the time of diagnosis, then your overall survival at 5 years is down to 30%. So it's key to finding it early, and mammograms is going to be that. And then continuing to have, it's okay if once you get diagnosed, it's a matter about meeting your team members and coming up with a plan. And that's where your surgeon comes in, and they will kind of act as your I call it the quarterback, like we kind of reach out and make sure what's the team approach and what's the best plan for you.
This is so good. So the key to everything we talked about today, from gynecologic cancers to breast cancer, is get screened, and get screened early. Stay on top of your appointments. Martin Johnson says, shout out to Sibley, shout out to Dr. Staples. We love you. Oh, that's awesome. Team members are watching. So it's to get screened early. And I think that is the key, that we stay on top of our health, not to procrastinate, make sure we do our yearly or every 3-year, gynecologic visits and that kind of thing. So we're wrapping things up in just a few moments, but I do want to hear from each doctor. I want to talk about if each of you could say one thing to the woman listening right now, what would you want them to know about their health? And we could start with, we could go in order. We'll start with Dr. Rizavi, and then Dr. Staples, and then Dr. Tran, and then Dr. Trenoski.
Sure. I would say, I know most of the women listening are probably very busy. They're taking care of families, taking care of multi-generations, and probably working as well. And I know that it can be a busy life, but we always tend to do is put ourselves last. But you need to be present for your family, and the best thing you can be is to be an advocate for yourself as well. And that really means screening, and includes, obviously from my standpoint, screening your mammogram. It takes less than 20 minutes to get it done. It's once a year, 20 minutes, and it can ensure that you're around for your family, healthy and for a long time.
That's so good, because we're taking care of everybody else, that sometimes we forget to take care of ourselves. We forget to schedule ourselves in. So that's really, really good. Dr. Staples?
Absolutely. I want to kind of echo that. I think that prioritizing your health is very, very important. Having a good relationship with your doctor and your provider, and feeling comfortable and open to ask questions. And if you don't really have a great relationship with your provider, then consider switching providers so that you do feel more open to discuss certain things, and things aren't if things aren't just right. And then the only other thing that I want to say is get your children vaccinated.
That's good. That's good. That's right. I've had a relationship with my doctor since I've had my children, and that's years, right? My youngest is now 23. So you know how long that's been, but it's a blessing, because now you have relationship, right? And they know history. And if you don't have that kind of camaraderie, find a doctor that gives you that kind of camaraderie, and make sure they're giving you the information that they need. Dr. Tran?
So of course, Dr. Razavi hit it. But I also want to say, if you do get diagnosed, it's okay. We have great treatment. I think it's a matter of getting in with the right doctors. We'll have a good plan for you. And there's the majority of patients will survive and beat the breast cancer. So don't be shy. Don't think it's a stigma. It's common, but it is curable.
Yeah. That's so good. And that makes me feel good because I told you we're going through it now with my sister-in-law. And it was really breathtaking or refreshing to hear the types of treatment that you now have, that everybody doesn't have to do chemo or radiation, that there are, that it's been advanced in both gynecologic and breast cancer and as to how you can treat cancers now. Because I think sometimes the treatment is almost worse than having the disease. Tolerating the type of treatment that you might need to get. So this has been really, really refreshing. Dr. Chernosky?
Thank you. So I think that the comments by Dr. Razavi and similar by Dr. Tran as applicable to their cancer also apply to our cancers. You need to have a good relationship. You need to get the screening. Obviously, the vaccination, absolutely. That's a big bang for your bucks. I think, though, one of the things that I do see, and it goes to the same vein as what Dr. Staples said, I think when you have a good relationship with those doctors that you're seeing on a regular basis, then you're going to be probably more likely to bring the attention of something that's going on. But if you're in that situation that something comes up, perhaps you don't have a primary care doctor, perhaps you don't even have a regular gynecologist that you go to. If you're noticing that something is not right, seek medical care. Sometimes denial is just a normal coping mechanism that we all go through. We say, you know what? No, it's just a little spotting. It can't be a big deal. But the reality is, it's better to be sure that it's not a big deal because sometimes time matters. When I see postmenopausal women that say, oh, I've been spotting for about a year, I get a nice chill in my heart because I'm thinking, oh my God, am I staring at somebody that has cancer for 1 year? So when you have a symptom, visit that website, the Foundation for Women's Cancer. If you're having symptoms, if you're having something that doesn't feel right, get it checked out. Don't be afraid. Get the details. And if you're told we need to do this little investigation, we're going to do this, we're going to do that, don't disappear. Follow through, just like you would follow through on everything in life. Continue following through to the conclusion of what is that investigation leading to. That's extremely important. And like Dr. Tran said, not everything is a death sentence. We can do a lot of good. There are so many people that are cured. Just today, I saw 2 people that are about 5 years out from a stage 3 endometrial cancer. And so it is very possible. Don't run away because it sounds scary. You can be cured. You just got to stick with the program. The science has advanced tremendously.
Mm-hmm. So we've got about 4 minutes. I really want to talk about that when you do get patients that has these diagnoses. I know you're the science behind it, and I know that you guys see them as faces as well. How do you present this information to somebody? Is it straightforward? Is it compassionate? Like, that's probably one of my fears. My father died of prostate cancer. My mother had colon cancer. So I stay on top of my colonoscopies. I stay on top of my, and I was her primary care, which makes me more proactive, right? For my own health, because I was there to help her walk through things. And she did well with her colon cancer. She actually passed of vascular dementia years after. So she, she survived. She was a colon cancer survivor. But again, because she was on top of all of her visits, watching her, seeing how things had changed in her body, they were able to catch it early and literally just remove that portion of the colon. She did very light chemo, so it wasn't that, the treatment wasn't too harsh for her. And I watched that, but I also watched the different doctors that took care of her, right? And the way that it was presented. How do you give that information, especially for those, for you, Dr. Razavi, when you see it as in their mammograms? I'll give you a few moments to just talk about that transition piece to those who are watching.
Yeah, well, I really do believe that it's important to be honest with a patient. And I think part of it is imaging, that when you say imaging really tells a story. And So oftentimes we'll show the patient the mammogram. We'll show that what it looked like before and what it looks like now, what the change is, and what concerns us about it. And patients are I think they're very interested in knowing exactly the details as much as they can understand. And part of our job as physicians is to explain it in a way that the patient can understand. So that's what we do. We make sure that we show the patient, answer as many questions as they want answered. Some patients don't want to know too much at the time of the biopsy. So we really go by what the patient wants. And then when we discuss it with the patient, thankfully, we are in a position where we can realistically tell them that the odds look great. Just what Dr. Tran referred to earlier, the survival rate from breast cancer particularly is very, very high, particularly with our patient population who are advocates for themselves and do get mammograms once a year. So it's easy for me, while it's not easy for me to give the news of cancer, but it's easy for me to be honest and say that you will do well with one of our surgeons, because most of our patients do well.
That's good. That's good. One other, you can take that question as well.
I think Dr. Razabi said many good things. The thing that I'd like to highlight is that I think in all human relationships, honesty is very important.
Yeah.
I think you have to have tact, though, because sometimes, for example, I like to get a feel for people, perhaps over the first 3 to 5 minutes. Where are they? How are they acting? How are they sitting? What are those facial expressions? Because the reality is that sometimes it takes more than one visit to get through information. So you got to parcel out, what am I going to cover today? Seems to be the major obstacle here today. How can I give the most information, but also make it useful? So I think you need to be, to some degree, a little investigator and kind of get a pulse for where is this particular person at? What can I provide today? And not being afraid to say, you know what, we're going to talk about this today, but I think we need to meet another time and kind of parcel it out. Because what happens is that sometimes you'll get people, all you have to do is look at them in the eyes. And sometimes you lose them. They start getting glassy. Sometimes the husbands start falling asleep. So you want to keep them engaged. You want some kind of life partner there with that person. It could be their friend. It could be their mother. It could be their husband. It could be their spouse, whatever the case is. But you got to break it down in a way that makes sense, that is understandable. And at least I'm sure it's the same with the breast. With the gynecologic cancer, because we've come so far, you address the emotional factor, but you got to start laying some layers of foundation of knowledge, because when it comes to the treatment, when it comes to the surgery, you're going to be adding further layers. And so you're going to find that the patient will benefit from all of this. So I think it's tact. I think it's listening to your patient and being able to address things no matter what level of education somebody may have.
That's really good. I asked the question because I know those that are viewing will probably cringe, right? Like, what do I do if I get this information? And I just kind of wanted to lay it out there that, like you said, being tactful and being truthful and being honest about it, and reaching out to these experts, right? Log on to hopkinscancerdc.org if you have any more questions, or for all the information that we just shared. It was refreshing to hear that the treatment for both breast and gynecologic cancers has advanced to that point where we don't have to get the aggressive chemotherapy and radiation all the time. Like, that's not always the option. As Dr. Tran said, it's not the one place you go. Like, there are options now. So, and that when you hear the C word, that it's not always a death sentence. I thank God for that. I think that's one of the things I walked away with today. So thank you, ladies. It's good to put a face to the voices that I've been hearing and speaking with Dr. Staples. So our final words is that a special thank you to Dr. Johns Hopkins Medicine, special thank you to Johns Hopkins Medicine cancer experts, all of you guys that are here today, Sibley Memorial Hospital and Suburban Hospital. Please visit hopkinscancerdc.org for more information. That's hopkinscancerdc.org for more information. And you've been listening to Real Talk About Women's Health, presented by Johns Hopkins Medicine and the National Capital Region. Thank you, ladies, so much. Have an amazing day.
Thank you
so
for
much.
having me.
Thank you.